Hello everybody, and today I bring to you congenital adrenal hyperplasia. This is a very important case discussion. In fact, this is a very important topic to be known by postgraduate students because congenital adrenal hyperplasia can be asked when you have a case of precocious puberty or pubertal aberrations. It can be asked in virilizing disorders or hirsutism also, and it's not a very comfortable topic for students I've seen, because every time that I've questioned people, they try to avoid these kind of endocrinal disturbances, and that's where your examiners tend to catch you. And that was my aim of making it so easy for you to understand. But just by looking at my lecture once, you are done for this topic. So let's not waste any time and let's begin with the discussion of congenital adrenal hyperplasia. I had promised it long back, and now I'm just fulfilling my promise. I wanted to tell you, I wanted to teach you this thing so that it becomes very easy for you to understand and very easy for you to remember. So let's start with congenital adrenal hyperplasia. So as it says that there is adrenal hyperplasia in this case, so what exactly is the physiology behind it? See, it's basically an autosomal recessive disorder, and that's nothing but actually defective steroidogenesis. So I'm just skipping these two and I'm going to the last. So if there is a defective steroidogenesis for whatever reasons, the enzymes are not present, there is congenital deficiency of the enzyme, or there is some other fault because of whatever reasons, the cortisol is not being secreted properly or not being synthesized properly. This leads to chronic elevations of ACTH, the hormone that controls the synthesis of cortisol, via the negative feedback system. The body is perceiving that there is no cortisol in the body, so it's giving a negative feedback, because of which ACTH is being secreted by the hypothalamus more. Because of this being secreted, there is overstimulation of the adrenal cortex, resulting in hyperplasia, oversecretion of the precursors, and because of the enzymatic defect. So as a result of which, the precursor of the thing gets more and more accumulated in the blood, and since the enzyme is deficient, it's not being secreted properly, as a result of which the precursors, they get accumulated in the blood, and the cortisol is still not being secreted or synthesized properly because the enzyme is deficient over there. To understand it one step better, I'll bring you to another slide, but right now what I'm trying to make you understand is that the cortisol synthesis is what is getting defected because of the deficiency of a few enzymes, but the body is comprehending it as decrease in the levels of cortisol, and is giving a negative feedback to the system, the higher centers, and they are secreting more and more of ACTH, because of which there is adrenal cortex hyperplasia, because it's making it under the influence that it has to be secreted. So the production of cortisol in the zona fasciculata of the adrenal cortex occurs in 5 major enzyme mediated steps, and if that enzyme is missing, adrenal cortex is just getting the message that you have to secrete that hormone. So in process of that, there is more and more hyperplasia of the adrenal cortex, but actually nothing is being finally happening. How? That I'm trying to tell you now. I'll skip these slides now. Just if you understand this slide, you understand CAH. I told you many times that if you understand the pathophysiology of any disease, just read the pathophysiology of any disease if you don't have time. So etiology will also be very easy for you, because etiology usually comes under genetic causes, idiopathic causes, trauma, infection, or tumor. All right, mostly. But yeah, of course, there are certain things which are just finished off with genetics and environment and metabolism and all that. Anyways, what I'm trying to emphasize over here is that if you understand the pathophysiology of any disease, you can make the etiology, you can make the clinical signs and symptoms, you can make the diagnosis, and you can even manage the treatment. So important is just this slide. If you understand this slide, you understand CAH. Now see, what happens is that there is this cholesterol over here. Okay, this is what has to go inside, and this star, as you can see, it's a carrier protein. The star is a carrier protein that lets the cholesterol enter the mitochondria. Now once that it enters the mitochondria, there are several steps through which this cholesterol is to be made into aldosterone, or this cholesterol is to be made into cortisol, or this cholesterol finally transforms into testosterone. And all these processes, all these steps, they all require enzymes. And if you can see the enzymes over here, the enzymes are, you have, of course, ACTH is what finally, makes these, undergo these processes. But the processes they are undergoing through these enzymes, 3-beta hydroxylase, okay, dehydrogenase, hydroxysteroid dehydrogenase. Then you have 21. Now this is the important enzyme. Usually this is missing. See, it's got that shadow. So 21 alpha hydroxylase deficiency is the classic form of CAH, congenital adrenal. Actually, this name, congenital adrenal hyperplasia, instead of that, if they would have given some deficiency, 21 hydroxylase deficiency, it would have been rather very easy for us to remember and comprehend and carry forward. But anyways, they've called it CAH, you say it, 21 alpha hydroxylase deficiency. So at least you'll know and you'll remember that there is some enzyme deficiency, and probably in the synthesis of cortisol. So finally what happens is that 21 hydroxylase deficiency is very, very common. Then the next common enzyme which is missing is 11 hydroxylase, and of course 17 hydroxylase also. These are three hormones, the enzymes which are missing in action. Now what happens? If they are missing in action, the precursors like over here, pregnenolone, progesterone, they are increased. Because it's not going any further. After 21 hydroxylase, the steps are just not happening because this enzyme is blocking the process to happen. That means this enzyme is not letting them go to aldosterone. So aldosterone is not being produced. This is aldosterone deficiency. Cortisol is not being produced because that's a rate limiting step as well over here. 21 hydroxylase is still needed to make cortisol. That is not, that enzyme is not also produced. So again, what is happening? The precursors, they are accumulating in the blood. That means pregnenolone, 17 alpha hydroxy, progesterone, which is one of the tests of CAH. Okay, but still 17-20 lyase is there. So everything, the precursors, they get, finally turned into DHEA, and androstenedione, finally testosterone is produced. So if there is a female baby, she'll have a virilizing disorder because even at birth, testosterone will be higher in quantity than it actually should be, because instead of aldosterone and cortisol being formed, it's all getting converted into testosterone. And that causes the virilizing effect. So the DHEA and 17 alpha hydroxyprogesterone, they are the classic diagnosing parameters of CAH. So if you understand this slide, you know it all. I don't have to go forward and tell you anything now, because now I'll just brief a little about these typical features. Now, the types of congenital adrenal hyperplasia are many, but the situation which can cause crisis and that you should be able to diagnose are these. Now the problem is that if any baby is born with ambiguous genitalia, very important for you is to immediately transfer her to a pediatric endocrinologist. Let them handle the situation, is because if suppose she has the deficiency of 21 classic 21 alpha hydroxylase, and if it's a salt wasting, see the last one where my cursor is, right now, if at all there is this kind of classic 21 alpha hydroxylase deficiency along with salt wasting, she or that baby is in crisis. Now if in case of males this thing happens, usually it results in death of the baby. Why? Because in case of males, you do not understand whether there is a virilizing disorder or not. So there are many centers in which this test is one of the important prerequisite prenatal tests for congenital adrenal hyperplasia. Because what if the baby had salt wasting? You could never diagnose it, and it was a male baby. Female baby you still can, but if it's a male baby how will you know? Because there will not be any ambiguous genitalia, there will not be any virilizing disorder. I mean, how will you say virilizing disorder for a male? So they are at big a problem, and many centers this becomes a very important test at birth. Of course, the ones who had a history or in which there is some kind of alert is there, you can still go ahead. But the ones in which there is no alert, the baby simply dies, and that happens because of salt wasting. So anyways, if in case of female there is a virilization, you have to definitely alarm and inform the pediatrician, and then they will transfer the baby to a pediatric endocrinologist, because in that case you'll have to go for 17 alpha hydroxy progesterone, DHEA, androstenedione. They'll all be elevated, and sodium potassium might be very, very low. Why? Because in this case there is salt wasting. Why? Because aldosterone, mineralocorticoid, the hormone which is required for the salt conservation, that is not there. Since mineralocorticoid, aldosterone, enzyme is not there, there is salt wasting. Similar thing happens in 17 alpha hydroxylase deficiency. Males are hypovirilized, hyperkalemic. How will you know hyperkalemia? And there'll be decreased androgen, estrogen, elevated DOC and corticosterone. Now let's see. These are all rare kinds, but very important kinds. Let's see the yes. So over here, if you can see, 17 alpha hydroxylase enzyme is somewhere over here, and it's leading to the formation of pregnenolone to 17 alpha hydroxy progesterone, and progesterone to 17 alpha hydroxy progesterone. That means this whole process will not take place. If this enzyme is not present. So now can you correlate it? It's very easy now. So if at all 17 alpha hydroxylase deficiency is there, just imagine the amount of deficiency of mineralocorticoid. Not just that, nothing is being formed. You can't go any further. That means pregnenolone and progesterone, 17 alpha hydroxy progesterone, that's the only thing which is accumulating. It's not going any step further. That means even males will be hypovirilized, and there'll be decreased androgens, obviously. Yes, correct. Then there is a deficiency of 3-beta. And now remember, these things that I'm talking to you right now, they are dangerous kinds but rare. The ones which are coming up, they'll be very common but not that dangerous. But anyways, the whole gist of these two slides is that you should just know that if any female is born with ambiguous genitalia, you have to alarm the pediatrician, and the pediatrician is going to henceforth take it up. Is because that in this case, the most important thing that has to be ruled out is what kind of enzyme is lacking over here. If it is a dangerous kind, if there is at all salt wasting, you have to immediately take care of the baby. So anyways, this is not to be taken into that depth. The only thing you have to understand is there are many kinds, but the salt wasting kind have to be treated with full sincerity. And what are the clinical features that you should know? So there is a female with no sexual development. Okay, there is salt wasting, thing that the salt wasting crisis that can happen. You should know that. Okay. Now we'll go further to understand. So females with classic 21 alpha hydroxylase deficiency and 11 beta hydroxylase deficiency, they present at birth with virilization in their genitalia, and adrenocortical function usually begins by 7th week of gestation. So a female fetus with classical CAH is exposed to adrenal androgens at a critical time of sexual differentiation. And that leads to clitoral enlargement, fusion, scrotalization of labial folds, rostral margin, migration of the urethral, vaginal, perineal orifice, many things, And now comes the 5 Prader stages which you should know. First of all, this name you should know, then you should know the stages. Stage 1 is clitoromegaly without labial fusion, as you can see in the first figure. The second is clitoromegaly with posterior labial fusion. Stage 3 is greater degree of clitoromegaly and single perineal urogenital orifice, almost complete labial fusion. Increasingly phallic clitoris, urethra-like urogenital sinus, and complete labial fusion. Stage 5 is almost penile clitoris, urethral meatus at the tip of phallus, scrotum-like labia, appear like males without palpable gonads. So it's almost looking like a male gonad, but except for the fact that obviously testicles are not present. So internal female genitalia such as uterus, fallopian tubes, ovaries develop normally. Females with classic CAH maintain the internal genitalia potential for fertility. So if there is gender correction, they'll be able to, have babies. which is very, very important. You should know these stages, because it's very, very difficult when the child is born with ambiguous genitalia to counsel the parents and to commit anything to them. So labial fusion has to be looked forward to, and what is the amount of clitoromegaly, that also has to be looked forward. Now, what could be the effects of this? So there is lack of appropriate postnatal treatment in boys and girls, results in continual exposure. So if at all you've not been able to recognize it, or you think it's something not so much to be talked about, or you do not raise alarm at the right time, then there is continued exposure to excessive androgens, causing progressive penile or clitoral enlargement and development of premature pubic hair, axillary hair, acne. Advanced somatic and epiphyseal development occurs with exaggerated growth and is usually accompanied by premature epiphyseal maturation and closure, resulting in final height that is typically significantly low. So this is basically one of the, sequelae, or one of the, disadvantages of this thing, CAH, and one of the DDs for precocious puberty. Excessive glucocorticoid treatment can also lead to poor growth, and mean age at onset of puberty in both males and females is slightly younger than the general population. So you should know that. In those who are inadequately treated, central precocious puberty can occur. And following the onset of puberty in majority of successfully treated patients, the milestone of further development of secondary sex characters in general appears to be normal. Anyways, that's not very important. What could be the postnatal effects? In female adolescents and adults, signs of hyperandrogenism may include, so male pattern alopecia might be there, acne. See, when I was presenting the case on precocious puberty, these things were mentioned when I was taking history. That whether there is any alopecia present or not, whether she's had any acne episodes. Right now she might not be having, but maybe previously she had. Hirsutism, how much is the pheromone Galloway scoring? What is the menstrual cycle like? Whether there was any, if she's a patient who's married, any impaired fertility and all. So in males you have short stature and impaired fertility. These are all different, different mosaic forms, let's say, of CAH, or different permutation combinations of CAH. It can manifest in different forms, because there are so many enzymes involved in cortisol, since anything at any point can be wrong. It could be a mixture of things as well. So this is the reason. Now, prenatal androgen exposure in females is affected with classical CAH. Not only has a masculining effect on the development of external genitalia, but also on childhood behavior. So both physical and behavioral masculization are related to each other and to genotype, indicating that behavioral masculization in childhood is a consequence of prenatal androgen exposure. This thing is not very much needed. So salt wasting CAH and non-classical CAH. So there are many who are like non-classical CAH. So you should just be able to understand and label the patient, whether it is a classical CAH or non-classical CAH, but nevertheless you should be able to diagnose. When there is a loss of 21 hydroxylase function is very severe, adrenal aldosterone secretion is not sufficient for sodium reabsorption by the distal renal tubules, and individuals suffer from salt wasting as well as cortisol deficiency and androgen excess. Infants with renal wasting have poor feeding, weight loss, failure to thrive. So all these signs give you a reason to look further, look deeper, and that's where you should have this as DD. Vomiting, dehydration, hypotension, hyponatremia, if you have all these answers, there are hypotension, there are hyponatremia. In babies, who checks the blood pressure, who goes for a electrolyte deficiency, unless all these other signs are there, like poor feeding, weight loss, failure to thrive. These are the signs which are more easy to pinpoint and obviously follow up. Adrenal crisis can occur as early as age 1 to 4 weeks. Affected males who are not detected in a newborn screening program are at a high risk for salt wasting adrenal crisis, because their normal male genitalia do not alert medical professionals to their condition, which is a very important and very powerful statement. It's important to recognize that the extent of genital virilization may not differ among salt wasting and non-classical. So we should be able to handle such cases, and this is why this thing is very, very important. Salient features of classical CAH are prenatal virilization and progressive postnatal masculinization with rapid somatic growth and advanced epiphyseal maturation, leading to early epiphyseal closure and likely short stature. So there is no evidence of mineralocorticoid deficiency in this disorder, and serum electrolyte concentrations are also normal. So this is not the typical classical. This is virilizing, simple virilizing, not salt wasting. Salt wasting is SW. Simple virilizing is the one which is the most common and not very dangerous type. This is just virilizing disorder. Uh, Diagnosis at birth of a female with simple virilization is very immediate because of the apparent genital immobility. Since the external genitalia are not affected in newborn males, hyperpigmentation may be the only clue suggesting increased ACTH secretion and cortisol deficiency. So these are atypical kinds. Anyways, I'm not taking it any further because there is different kinds. There is salt wasting kind and there is simple virilizing kind. They are complete congenital kind, but they're not non-classical forms as well. So there are different kinds, but the important thing is here how to diagnose. So ambiguous genitalia is one. The physician is obliged to make the diagnosis quickly as possible to initiate therapy. In randomly timed blood sample, a very high concentration of 17 hydroxyprogesterone, the precursor of defective enzyme, is diagnostic of classical 21 hydroxylase deficiency. So if there is 21 hydroxylase deficiency, what will increase? 17 alpha hydroxyprogesterone. The gold standard for hormonal diagnosis is actually corticotropin stimulation test, which hardly is done. Over here, what you do is you take 250 microgram of post-syntropin, give it intravenously, and measure the levels of 17 alpha hydroxyprogesterone and androstenedione at a baseline and 60 minutes. So first of all, give baseline, and then after 1 hour, just see. So if at all, what do we give? Corticotropin stimulation test. So how do we get to understand this particular test? Through this particular way. If at all the levels they increase, then you automatically get to understand that this was CAH because of the deficiency of 21 alpha hydroxylase. Classical. Establishing a genetic diagnosis is not important. For 21 alpha hydroxylase deficiency, CAH genetic analysis of CYP21A2 gene may provide more clues, but what was most important is what I already told you. 17 alpha hydroxylase progesterone levels, they are useful tool for early detection. Let's skip it now. So prenatal testing for CAH in utero has historically utilized invasive techniques like amniocentesis CVS, which cannot be done prior to 14 weeks of gestation. Prenatal dexamethasone treatment must begin prior to genital formation occurring at approximately 9 weeks in order to avoid. So those females who already know who have this deficiency, if they are turning pregnant and they have this thing already discussed with their your gynecologist, they can of course start their treatment with dexamethasone. So the treatment, it's very simple. The treatment has to be to give those hormones which are not present in the body, which are not being synthesized, as simple as that. So goal of therapy is to both correct the deficiency of cortisol secretion plus suppress ACTH overproduction. So if you start giving, glucocorticoid, you reduce the stimulation to androgen pathway. So you prevent the virilization. The usual requirement of hydrocortisone for the treatment of classical 21 alpha hydroxylate form is about 10 to 15 milligram per meter square per day, divided into 2 to 3 doses per day. And for non-classical, it is around 5 to 10. So for classical, it is just double almost, okay? 5 to 8 milligram per meter square per day divided into 2 to 3 doses per day. Hydrocortisone is actually the glucocorticoid of choice. That's what you want to give. Prednisolone, dexamethasone, they're not used in growing children. They have some growth suppressive effects. Rest of the things are not so important. What was important, I've already told you. Let's skip it. So, one thing which I would just like to tell you is that advancement of the bone age is monitored by bone age x-rays, which is very, very important. But sometimes you might require growth hormone therapy to affect the final adult height. This is what I wanted to tell you about CAH, and I hope I've been able to make you understand a little bit. Even if you've understood just the gist of it, you do not remember so many, enzymes, and you still don't remember the doses. I think that's just fair enough. Nobody expects you to know. In fact, many examiners themselves do forget the doses. If you fumble in front of them, it will not give you a good impression. So if you do not remember the dose, I'm sorry, sir, I do not exactly remember the dose. But the only thing I know is that hydrocortisone is a glucocorticoid of choice, and the dose in classical vis-a-vis the dose in non-classical is half of what should be given in classical form. So this you can say. And as far as your growth hormone is concerned, yes, growth hormone is the final hormone is required to finally increase the height of the baby, the child, and that might be required in case of your classical form more than non-classical form, because in that case the height is more stunted and the effects are more severe. So I think with this you've been able to understand CAH much better than it was before. And just go and see that slide which I showed to you in the beginning, the one which tells you about the pathophysiology, and that will clarify so many doubts and so many things. But the most important gist is that you have to give those enzymes which were deficient to begin with. That is actually the gist of CAH. So thank you so much.